I think Marcus is ready if you want to go ahead. So Dr. Marcus Way will be presenting us the what is new with GINA. And Dr. Marcus Way is a family physician based in Moncton, New Brunswick. He runs a full time family medicine practice and provides a part time hospitalist care at the Moncton Hospital, where he currently serves as the head of the Department of Family Medicine.
Excellent. Well, thanks everyone for attending. So these slides were prepared by GINA. There's a lot of them. I wasn't allowed to take them out, so I'll try to blaze through them. For conflicts of interest, I had received a number of years ago fee from Sanofi, but that was for Synvis. I did in 2022 get a honorarium from AstraZeneca. They're the makers of Symbicort. Um, so to keep that in mind, I was part of the Canadian Thoracic Society Guidelines Committee as well, so which is a competing guideline. So obviously, I think the Canadian ones are better than GINA, but that's my conflict of interest. I am a family physician, not a respirologist, so I do see a variety of medical conditions. Um, so the GINA updates their guidelines every year. So there isn't any necessarily any revolutionary changes to the new one, but there are a few. A lot of them are more aesthetic, but there was a big update on type 2 biomarkers. Before it was more of a discussion about them, and now there's actually advice on how to use them. It's still have limited utility for the most part. The treatment recommendations, some minor adjustments. Um, Diagnosis of asthma in children younger than 5 years old, where we can't get spirometry. That there was a major update. Now it's much clearer when you can diagnose asthma, whereas before it was somewhat using your own clinical judgment. And following up with the last presentation, the impact of weather is now discussed. GINA now discusses what impact whether either heat or thunderstorms or even cold spells have on asthma. So we'll start with the talking about the diagnosing asthma in adults and children above 6 years and older. So that's when you can get spirometry. First off, you need clinical presentation that's compatible with asthma. So you still have to do a history and physical exam. Um, you know, that's what's asthma is a little bit more complicated than some other diseases where you can just order a test, and if the test is positive or negative, you can rule it in or out. Um, if there are alternative diagnoses, because the symptoms cough and shortness of breath, like we've seen before, there are dozens of health conditions which can cause this presentation. But if it looks like asthma, ideally get spirometry. If you live in a community where spirometry isn't available, you can do peak flow, pre-post bronchodilator. Um, if you if the lung function testing shows variable uh, airflow, um, then you have your diagnosis for asthma. Um, if it doesn't, or spirometry is not available, you can consider using biomarkers, so FeNO and eosinophils, to help in the diagnosis. Um, if you still are unable to, you still don't have a diagnosis, but you suspect asthma, you can treat empirically with ICS and repeat spirometry or follow up for symptoms. And if you have improvement, significant improvement, that supports your diagnosis. So the criteria for diagnosis will go into each section. Julie, So the typical symptoms of asthma is wheezing, shortness of breath, chest tightness, cough. Uh, and asthma tends to be variable over time. So there's, a lot of other conditions that cause shortness of breath, like let's say they're anemic. They're not going to have good days and bad days. It'll be, um, or, pulmonary fibrosis. It just gets worse. You don't have the big variability that you see in asthma. Symptoms are often worse at night. Triggers, something to explore. And what's very specific for asthma is the shortness of breath that comes after exercise. So, of course, of most lung diseases, they'll be short of breath when they're walking up stairs or going for exercise. But if it persists for half an hour to an hour afterwards, that's very specific for asthma. So lung expiratory lung function variability, that's the um, objective criteria for diagnosing asthma. And there's a number of ways we can get this. One, the classic is post-bronchodilator. So you do spirometry, give them their salbutamol, and repeat. And if there's an improvement of 12% or and 200 milliliters, get your diagnosis. If you only have peak flow, you need a larger increase. You can have variability within a day. So I think this is a little bit less practical, but if you have variability within the day, you can have an improvement with treatment of ICS. So this is something that I think a lot of people overlook. Let's say you do spirometry and it shows obstructive lung disease without reversibility. So most people would recognize that as COPD. And the patient, let's say, is a frequent exacerbator. So you put them on an ICS containing treatment, so maybe triple therapy. And if you repeat the spirometry later and there's a significant improvement, then you actually have COPD. So either asthma and COPD, or just asthma. So that's one of the things that makes it really complicated. Even if your spirometry shows that doesn't support the diagnosis of asthma, the patient may still have it. There's the bronchial provocation test, so methacholine typically. If there's a drop in FEV1 with use of methacholine, that's diagnostic of asthma. And variation in lung function between visits. So if you do spirometry one day and maybe it's a good day, the weather is nice, and they get it's fairly normal, but you repeat it a few months later, maybe we have smoke, forest fires or something, and you get that 12% and 200 milliliter change, might be diagnostic in the proper clinical context, diagnostic of asthma. So type 2 biomarkers, and that's something maybe we don't classically use very much, but is gaining attention. There is some clinical utility in diagnosing asthma in phenotyping. So there are recognized 4 phenotypes. You have either type 2 inflammation, which is dominantly eosinophils. You have your type 1, which is neutrophils. There's mixed, which is 1 and 2, and paucigranulocytic asthma, which is kind of non-inflammatory asthma. So if the patient has a clinical history that's compatible with asthma, and you're not able to get a diagnosis supported with spirometry or peak flow, pheno of greater than 50 in adults or 35 in children supports the diagnosis. This is patients not taking an ICS. Corticosteroids will normally decrease the FeNO, so the cutoff is a little bit lower. Eosinophil count above the reference range, so it would be 0.5 on the blood results we're getting back. However, like I said, there's different asthma phenotypes. So FeNO and eosinophils are only elevated in type 2 inflammation, which accounts for maybe roughly half of all asthmatics. So 50% of asthmatics will have negative biomarkers. So if that comes back normal, it doesn't rule out asthma. Also, these exams are very variable. So it's recommended if you still have high suspicion, you can repeat them, see if it up to 3 times to see if it changes. There's a lot of factors affecting blood eosinophils. They're between gender, smoking, if they're taking ICS, if they have other comorbidities. And there are a lot of factors affecting FeNO as well. So to take that into consideration, they're not the most reliable test, which is why they have their limited utility. So again, the test can help in phenotyping. High FeNO, high eosinophils, either in the blood, sputum eosinophils and IgE, which we could mention here as well. And the utility of phenotyping is that there are some asthma therapies, specifically biologics, which work much better in type 2 inflammation. Unfortunately, we don't have any treatments specific for type 1. I'm hoping in the next few years, maybe like IL-8 monoclonal antibodies, but that's currently, unfortunately, all of the attention has been going to type 2 inflammation. It does have its utility in predicting risk for exacerbation. High eosinophils and FeNO are associated with higher risk. You can also use FeNO to assess compliance with treatment. So if the FeNO doesn't decrease, then maybe the patient either isn't taking the inhaler properly or they're not taking it at all. So you might want to review with the pharmacy if they're filling their inhalers, or review inhaler technique. Also, with low eosinophils and FeNO, it may affect treatment decisions for the more severe asthmatics. Spoke of that. Personalized treatment, or it's easy to follow an algorithm, but you have to consider the patient in front of you. And asthma is complex. There could be a lot of things like obesity, smoking, allergies, what kind of insurance they have, other comorbidities. If they have arthritis, and they have a hard time using certain types of puffers. They don't like the dry powder. And there might be other comorbidities that we can treat to help improve asthma outcomes, such as obesity, smoking, GERD. So GINA advocates for shared decision making. You want to consider what medications help for symptom control and reduce risk. Want to look at the patient's goal, and sometimes their goal might be different from ours as clinicians. Can the patient understand how to use the inhaler? Because there are some studies that show that many patients aren't using them appropriately. Cost is a huge consideration, and environmental impact of asthma treatments as well. With a meter dose inhaler, like Ventolin, for example, I read one study that it's equivalent to about 19 liters of gasoline being burned. So it's they're using a lot of inhalers. It's not negligible. It actually says the same thing. So there are two goals of treatment in asthma. One is to help to control the symptoms, so that your patient isn't woken up at night with cough or shortness of breath, that they're not impaired in the physical activities, they don't stay home from school or work. And that's the second, which is gaining more attention in the medical world, is reducing risk of exacerbations primarily. So a patient can have well-controlled asthma, but still be at risk for exacerbation. And that's one of the reasons why patients will, you prescribe them SABA and an ICS. They keep using their SABA because it's helping to control their symptoms, so their symptoms are well controlled, and they stop taking their ICS. So you want to, as mentioned, consider the clinical features, their phenotype, what other diseases they have. And if the asthma is severe, obviously consider referring to an expert, because there are a lot of other treatments beyond the inhalers. And it might get a little bit more complex. Remission is an interesting concept. Many children diagnosed with asthma will eventually grow out of it. So if you have a child under the age of 6 and their parents say, well, will my child be on puffers the rest of their lives? There's a 59% chance that eventually when they grow up, they'll come out of it on their own and not need any medication. Of course, the older you get, the less likely it is you'll go into remission. And adults who had asthma as a child can still get asthma exacerbations. Keep that in mind. Let's say if they get a viral infection, so you might still be treating them with prednisone. The other type of remission is there's remission on medication. Usually it doesn't happen on ICS, and the ICS, maybe 2 to 3% of patients will have no symptoms and no exacerbations on ICS, but with the new biological treatments, about a quarter to a third of patients might actually go into remission, meaning they essentially are symptom free and wouldn't be able to tell they have asthma. It's not a cure because they still require treatment and they still have the underlying disease, but it's a pretty impressive advancement. Just repeat what I said. Watch out for over-treating patients as well. So if their asthma is a little bit less well controlled, you can go to high-dose ICS regimens, but try to limit it to 3 to 6 months until they come under control, then taper down. Because high-dose ICS is associated with pneumonia and even atypical types of pneumonia as well, and there may be some systemic issues like decreased bone mineral density. It's part of the reason GINA encourages their track 1 treatment, which is PRN ICS for Moderol, because the patient only increases their inhaler use when they have increased symptoms and is able to taper down on their doses on their own without seeing the busy clinician all the time. Assessing asthma control, like we said, there's 2 components, which is symptom control and outcomes, exacerbation being the big one. But in theory, exacerbations can lead to permanent airflow limitations like COPD, permanent loss of lung function. Same principle as with rheumatoid arthritis. If rheumatoid arthritis is properly treated, you end up with permanent joint damage. Same thing can happen with lungs. You also want to look out for medication side effects. The inhalers are typically well controlled, but failure, anxiety, maybe glaucoma, and consider steroid use, especially say they have edema, um, chronic rhinosinusitis, so they're taking an inhaled steroid, a nasal steroid, and then a topical. It does um, build up. So the checklist, the questionnaires for symptom control, that hasn't changed. Symptoms, either daytime symptoms or SABA use more than twice a week, and nocturnal symptoms, and of course, limiting activity to asthma symptoms. So factors associated with an increased risk of exacerbation of the patient. The more SABA canisters a patient uses, the increased risk there of having an exacerbation, and that increases linearly with each canister. It's nice that in 2025 we can actually look on the pharmacy record, because patients usually aren't very honest about this. So not using ICS is another risk factor, or not using it properly, non-compliance or not being prescribed. There's several comorbidities, including obesity, chronic sinusitis, allergies, pregnancy, exposure to irritants, low socioeconomic status are higher risk, worse lung function as well, and the high biomarkers and history of exacerbation. So someone who exacerbates is obviously more likely to exacerbate in the future. So the question is, why do we need to worry about giving ICS to mild asthmatics? Well, turns out a lot of about a third of the acute exacerbations are in patients with only mild asthma. And a significant portion of patients who go to the ICU or even die of asthma have mild asthma. Low dose ICS is very effective, so it doesn't take much to reduce the risk significantly. And of course, patients who have infrequent symptoms aren't interested in taking medication, often aren't interested in taking puffer every day for something that's only occasionally symptomatic. Oral steroid use does carry a cumulative risk. So one course of steroids, an exacerbation probably isn't a big deal, but over the years, 4 or 5, it adds up. You can get osteoporosis, diabetes, other things. Regular use of bronchodilators, so SABA, like Ventolin or Burkinol, you end up with it increases airway hyperresponsiveness. So there's increased inflammation. It's also associated with the increased mortality. And it's also trains the patient to see the SABA as the better treatment, because the ICS, of course, it takes a while to work. So in 2019, it's when GINA changed the treatment algorithm. That their preferred treatment, or the recommended treatment, is for mild asthmatics to use PRN ICS for Moderol. In Canada, the only one that is evidence-based is Symbicort, and adult patients can take up to 12 puffs a day. There is a study on beclomethasone for Moderol, but that's not available in Canada. Zenhale which is mometasone for Moderol, and according to the monograph, you can use up to 12 puffs a day. However, they didn't do any studies for use as PRN or MARC, which is maintenance and reliever therapy. So the first step would be PRN. These Symbicort in this case. Second would be low dose. So low dose would be 1 to 2 puffs of Symbicort per day with as needed. Medium dose would be 2 puffs BID. And then step 5, you have a whole lot of options, a lot of things to consider. The alternative track, of course, Symbicort might not be covered by everyone's insurance plan, and it's quite expensive, about $130 for an inhaler. So if you prescribe SABA, it's recommended to take an ICS with each dose of SABA. There are studies for this, and there's studies on a single device ICS SABA. That would be, again, with beclomethasone, but that's only available in Europe. It seems the Europeans like their beclomethasone. So step 1 would be SABA and ICS as needed. Step 2 would be maintenance ICS with as needed SABA plus or minus as needed ICS. Step 3 would be ICS LABA, low dose, increase the dose. Step 5 is the same. Alternatively, if people don't like inhalers, there is some evidence for reduction of exacerbations with tryptophan receptor antagonists. To be Montelukast or Singulair. Tends to work better in children, and there's actually really good data on Montelukast for exercise-induced asthma. So again, the reasons why ICS formoterol is preferred. It has been shown to reduce exacerbations, and it reduces the total amount of ICS given to patients, because if they're only using it when they need it, when symptoms are higher, you end up with about a quarter of the amount of ICS as the regimens of the daily ICS. So change step 4 now recommends just medium dose ICS LABA, though you can increase to high dose temporarily for a maximum of 3 months. Always consider treating comorbidities, smoking cessation, vaccinations, pulmonary rehab, immunotherapy. So now we have sublingual immunotherapy, which is for patients who have allergies. There appears to be some benefit to asthma control with weight loss, so diet and exercise has shown to improve it. There's currently a study with Ozempic for asthma, and it'll be published next year. So now it's going to be used for everything. Oral corticosteroids, try to avoid them at all costs. They're very effective, but they're horrible. So compared to SABA alone, the ICS formoterol reduces exacerbations by about 2/3, hospital visits and symptoms. Compared to daily ICS, it depends on the type of study. If it's a traditional randomized controlled trial, they're very similar. The daily ICS does improve symptoms a little bit compared to the PRN Symbicort. But in pragmatic trials where the prescription, the puffer is given, it's not blinded and kind of similar to what we do in real practice, because the compliance is low with ICS. Symbicort does better in reducing exacerbations. It works for type 2 inflammation and type 2 low, so the neutrophilic and paucigranulocytic. The MART, so maintenance and reliever therapy, so taking Symbicort regularly and plus PRN, has been shown in pragmatic trials to be better than the classic ICS LABA with PRN SABA. Also, there's also been head-to-head studies for formoterol versus salbutamol, and formoterol reduces exacerbations without the STS. Already went over that. This table just shows the comparative doses of different ICSs. So what's low, medium, and high? Fluticasone furoate, that's new to the 2025 because we know that it's not the same thing as fluticasone propionate Flovent. All right. So children's a little bit different. We don't have the same studies for them. There is no study using PRN Symbicort in children under 12. So the current recommendation is to give SABA and plus ICS PRN as step one. You could so use PRN Symbicort or the other inhalers, but they would be not evidence-based. They weren't included in the studies. But I have seen down Symbicort approved down to 6 years, and even some places say down to 4 years old at the lower dose, so at 100 milligrams instead of 200. So step one, PRN SABA ICS. Step two would be daily ICS, or alternatively Montelukast. Montelukast seems to work better in children than adults. Step 3 and 4 looks a lot like for adults. So in children younger than 5, now this major update is they tell us how to diagnose it, whereas before there was more discussion of when to suspect it. If the patient has wheezing episodes of bronchitis, they have multiple wheezing episodes or one with asthma-like symptoms in between, and you don't have another explanation for their symptoms, one of the many other things that cause coughs and shortness of breath, and they respond well to either SABA or a 2 to 3 month trial of ICS, then you can give them a presumptive diagnosis of asthma. If they only 1 or 2 of the criteria are met, you can diagnose with suspected asthma, continue follow-up and treatment. But obviously, it's because children can't get spirometry at that age. So if, this is just a list of the many other things, symptoms that can present similar to asthma. If the first episode of bronchitis is before 1 year old, probably bronchiolitis, and it's less likely to be asthma later on. So if you suspect asthma in a child younger than 5, consider giving them Ventolin for SABA plus or minus ICS. Low dose, of course, for the ICS, not the adult doses. Treatment algorithm. There's really very little evidence for the step 1 approach. Unfortunately, more is needed. Strong guidance. With step 2, if they have persistent symptoms, daily ICS, you can increase it as needed up to quadruple the dose during a viral infection or an exacerbation. Difficult to treat asthma. You could consider alternative diagnosis, especially if they've had well-controlled asthma and then all of a sudden it's getting worse later in life. There's things like allergic bronchopulmonary aspergillosis. There's Church-Strauss, NSAID-induced asthma. obesity related. Um, Running out of time, Aaron.
Yes, we are.
Um, okay, so maybe just end that there and leave it for questions.
Uh, we don't have any questions right now. I just have a little question on my side. With severe allergies, is there a relation between asthma? If
Is it
the if someone with bad allergies as a kid can develop asthma, is there a percentage of that, or it's not related?
there? It's related to the phenotype. So patients who have allergies and eczema, uh, they're just genetically at higher risk for developing asthma, and they can have allergy-induced asthma as well. So I think there are plenty of patients who won't have any symptoms unless they go into the pet store, uh,
So,
or
do you have a percentage of the population that could develop asthma because of their severe allergies?
I don't have a percentage.
Okay, but it could be a factor.
Absolutely, and treatment will of the allergies either avoidance or even slit sublingual therapy will help to improve asthma control.
Well, thank you very much to answer my question, and thank you for your presentation today. It was very informative, and as we know, everything the updates always change in a couple of years. So um, thank you very much to update us about mild asthma.